Yes, good morning. It's August 22nd at 9:36, and I'd like to call the meeting to order with the first item of business being handled by Dr. Domino with the rules hearing.
Thank you, and I will start the script for this portion. This is just a little housekeeping. So good morning, everyone, and thank you for joining us today. I'm Amelia Boyd, and I'm the program manager for the commission and the organizer for this rules hearing. This hearing is being recorded and will be made available sometime next week on our YouTube channel. The documents which will be discussed here today are on the event calendar on our website, which is wmc.wa.gov. This hearing is being held in a hybrid format with virtual and in-person participants. So here is the agenda for our hearing. Before the close of the hearing, we will discuss next steps. At this hearing, the commissioners will listen to testimony, discuss written comments, and vote on the proposed language for this new chapter. Oh, it's not new chapter, sorry. For this rule. When the hearing is open for testimony, please keep the following in mind. The commissioners will only consider comments directly related to the proposed rule language. If your testimony falls outside of the rulemaking effort, you may be asked to hold your comments. You will have approximately 2 minutes to speak. If your written comment is included in the hearing materials, it has been reviewed, and any relevant comments will be considered by the commissioners in this rulemaking process. Please refrain from testifying if your remarks are merely a repetition of your written comments. So I will begin the roll call of panelists and staff. When I call your name, please introduce yourself. Let me get back over there. Okay, I think Dr. D'Souza is with us online, so if you would go ahead.
Hi, I'm Anjali D'Souza. I'm a physician and a commission member.
Dr. Jager.
Hi there, I'm Dr. Jager. I'm a pediatric ear physician, commission member.
Kyle.
Good morning. Kyle Kiernan, Executive Director for the Commission.
Dr. Trescott. Commissioners. Mr. Pullen.
My name is Douglas Pullen. I'm a commission member.
Thank you. And then go ahead, Mr. Rogers.
Scott Rogers, Public Commission Member.
Dr. Chung.
Jimmy Chung, General Surgeon, Commission Member.
Mr. Lopez.
Good morning, Ed Lopez, PA, hospitalist and a commission member.
Ms. Blake.
Good morning, Christine Blake, public member of the commission.
Dr. Murphy.
Good morning, Terry Murphy, emergency physician, current chair of the commission.
Dr. Vendura.
Elisha Mvundura, Commissioner, OBGYN.
Dr. Chang.
Hi, I'm Po-Shin Chang. I'm a family medicine physician. I'm a commission member.
Dr. Curry.
Diana Curry, OBGYN commission member.
Dr. Domino.
Hi, Karen Domino. I'm an anesthesiologist, and I am the presiding officer for this rules workshop. Today is Friday, August 22nd, 2025, and it's now 9:41 a.m. This meeting is being held by a Teams webinar and in person in the Department of Health located at 111 Israel Road Southeast in Tumwater, Washington. The proposed rule being considered today is establishing the use of nitrous oxide in office-based surgical settings. For today's hearing, all comments will be summarized and a summary will be provided as part of the CR-103 rules package when filed. Please do not interrupt individuals who are testifying. This hearing is being conducted in accordance with the Administrative Procedure Act, Chapter 34.05 RCW, and is being recorded for the official record in compliance with its requirements. The proposal, or CR-102 rules package for this rulemaking was filed on June 30th, 2025 at the Code Revisor's Office as Washington State Register, or WSR, number 25-14-080. Are there any questions regarding the rule or the hearing process before we begin the testimony? Please note that the questions asked during this part of the hearing are not considered testimony and will not be included in the rulemaking record or file. Are there any questions about this? Seeing none, I'd like to move on. The proposed language for this rule is included in the meeting packet. It's also available on our website at wmc.wa.gov. Ms. Boyd, could you please provide an overview of the proposed language?
Thank you, Dr. Domino. This rule allows physicians to use nitrous oxide in office-based settings if they follow all of the rules in the new section, which is WAC 246919-603. And this slide speaks to, I'm so sorry, it speaks to what the new section covers.
Any other comments, Ms. Boyd?
I'm going to go ahead and just read that for the benefit of everybody online.
Okay.
The proposed new section exempts the use of nitrous oxide in office-based settings if nitrous oxide is less than or equal to 50% concentration. It also exempts it if there are no other inhaled anesthetics, sedatives, or opioids being used, and all safety safeguards are met.
Any other comments, Ms. Boyd?
Oh, you put it down. It doesn't appear there is.
Okay, so we can move on with the testimony portion. Is that correct? Or are we still sorting out a hand raised? No.
Okay, we can move to testimony.
We'll now begin the testimony portion of the meeting. When testifying, please focus your comments on the content of the proposed rule. When you testify, please state your name, your organization or individual you represent, and whether you support or oppose the proposed rule. For those attending in person, we will invite you to testify in the order in which you signed in. If you wish to testify but have not yet signed in, please do so now. The sign-in sheet is located near Ms. Boyd, which you see right there in the middle. If you are participating virtually, please use your raise hand feature when you're ready to speak. We will call on you and unmute your microphone. Each speaker will be allowed 2 minutes to provide testimony. If your written comments are already included in the hearing materials, they have been reviewed, so we ask you not to repeat them during your testimony. We will begin with those present in person and then move on to virtual participants. I now open the hearing for public testimony. Ms. Boyd, who is the first person signed in to testify?
So there's no one signed in person, but we do have at least one hand raised. It's Billy.
Good morning, everybody. Billy Dickinson with the Washington State Medical Association. We appreciate the opportunity to provide comment and our support for this rulemaking. The WSMA has supported this rulemaking from the beginning. And we believe that this language will ensure patient safety by applying consistent standards for competency and the use of nitrous oxide in office-based setting. It will also improve efficiencies in our healthcare system by moving care from the ambulatory surgical setting to the office-based setting. This is good news for patients and physicians alike. We've really appreciated the opportunity to work with the WMC commissioners, Dr. Domino in particular, and staff on this rulemaking, as well as the revisions to the interpretive statement that previously governed this area of practice. Thank you for the opportunity to share our support.
Thank you. Ms. Boyd, is there someone else? It looks like I see another hand raised.
Sorry, Deborah?
Yes, good morning. I just want to clarify. I know that our written comments have been included in the packet. So is it true you don't want me to testify verbally?
Let me just say that we don't want you to read exactly what you wrote down, but if you wish to briefly summarize them, that would be great.
Thank you. I'd be happy to do that. So I'm Deborah Nucatola. I'm the Chief Medical Officer at Planned Parenthood, Great Northwest, Hawaii, Alaska, Indiana, and Kentucky. I wanted to share our deep concerns that certain aspects of this regulation are either going to force health providers, including Planned Parenthood, to not be able to provide nitrous oxide or increase the costs of care for our patients. A few concerns: this regulation is actually more restrictive than the previous guidance from the Medical Commission that we've been using, and that I believe has been guiding the safe use of nitrous oxide in clinic settings since 2023. The first concern that we have is that the proposed rule would require a second licensed provider. So someone like a certified registered nurse anesthetist, a physician assistant, or an advanced registered nurse practitioner to be present for simple and routine outpatient procedures like IUD insertions or IUD removals. It would require us to overhaul how we staff our health centers and disrupt our operations, which would lead to increased operational costs. And it's more restrictive than the current clinic-based practice. So eliminating this requirement would allow us to use support staff, such as our medical assistants who are already certified or registered with the Department of Health after they've received relevant training to ensure that they're competent to both assist and monitor patients choosing nitrous oxide for minimal sedation. Second, we wanted to specifically talk about the proposed mandate that providers use a scavenging system, and want to urge you to consider alternatives to this. This mandate doesn't follow either CDC or OSHA recommendations, or again, the previous interpretive statements, and would require us to invest heavily in facility renovations and upgrades to provide, again, a very basic service. It's also worth pointing out that dentists are not subject to the same scavenging system requirement. And finally, I just wanted to close by saying that nitrous oxide is an excellent option for many of our patients who want minimal sedation during minor procedures. And we're proud to provide this as an option and urge you to adopt a final regulation that does not harm our providers' ability to offer it. Thanks for this time.
Thanks for your testimony. Looks like there's another hand raised.
Is that me? I wasn't sure if I should wait for my name to be called.
Oh, yeah, you're labeled as Jessica Go.
Yeah, Jessica Gu.
Go ahead.
Okay. So I'm Jessica Gu. I'm a family medicine doctor and women's health provider. I work at Cedar River Clinics in Washington. We have clinics in Tacoma, Renton, and Yakima. And I just wanted to offer some similar comments to what Dr. Nucatola was discussing in terms of how this legislation would negatively impact our ability to provide care for our patients. So as you might imagine, a lot of our patients come from backgrounds of trauma, either physical, emotional, or sexual abuse when they come in for their procedures. Sometimes their procedures are necessitated because of that. And we like to provide as many different modalities of anesthesia as possible, and nitrous oxide is one of those, particularly for people who cannot drive because of its fast on and off. It's a really great alternative for people who don't have the social resources to necessarily have a driver. Our two main concerns are similar, that the language is quite broad. And so it doesn't distinguish between continuous administration of nitrous oxide versus demand. Our clinic uses demand. So the demand flow means that the nitrous oxide is not flowing continuously. There's a mask, and when the patient triggers it through an inhalation, the nitrous oxide flows. And so the exposure to the rest of the staff in the room is quite low. And so we would say that for the demand form, if you're using demand form, you don't need a scavenging system. That would be prohibitively expensive for us and basically mean that we couldn't provide nitrous oxide for our patients. We have been using dosimeter badges in our clinic for our staff to make sure that exposure levels have been low OSHA. And the first set of badges just went off and came back, and there was, not only were we below the requirements, it was completely undetectable. And so, and we plan on continuing to do these sort of dosimeter readings as this program goes periodically. And so we would request that the legislation sort of clarify between continuous flow requiring scavenging, but demand flow not requiring it, because as I said, it would not cause any, it would not add any extra safety, but it would cause a lot of barriers.
Thank you. That's your time. I'm so sorry.
Thank you. Is there anyone else who would like to testify?
Diana Levine, you can go ahead, or Dinah Levine. Remember to unmute yourself.
You may need to change the microphone settings in Teams. Yep. Is she talking?
Yeah.
Looks like you're muted still, or I think I see your voice, mouth moving. Not sure.
Better? We briefly heard you.
Is Yeah, we heard you briefly.
Can you hear me now?
Yes.
Yes.
Mine says I'm unmuted.
We can hear you now.
We can hear you.
All right, well,
Can you not hear us? Can we send her a message and say we can?
okay, so can
Yeah.
you hear me now?
Yes.
Yes.
Can you hear us?
Too many devices. I can hear you. You can hear me. Great. Sorry
Yes.
to take a minute. My name is Dina Levin. I'm the medical director of women's care at Whidbey Health on Whidbey Island. We're the only medical facility on the island that we're hospital-based, but also office-based. We're a rural health clinic. We're looking to set up a nitrous oxide for our clinic use to do IUD insertions and other procedures. And I just want to be sure as we're putting these regulations in place that they aren't overly onerous, and that, I know in dental offices, they're very, it seems like there's a lot less rules than in physician offices. In our case, we have a hospital right across the street, but I know other people don't. And you just want to be able to take care of women safely, but don't want so many regulations that it's onerous, like that we have to have crash carts or overly unnecessary scavenger systems, as have already been um, um, talked about. Thank you.
Thanks for your testimony. Is there anyone else who would like to say anything?
Heather, would you like to go ahead? Okay. There's no other hands raised. No one in person.
So no other hands raised? Well, then great. Is there anyone else? I said there's no one else wishes to testify. We'll close this testimony portion of the hearing. Has the department or commission received any written testimony from members of the public related to rules filed under WSR number 25-14-080?
Yes, the written comments were available in the materials for this meeting. You can discuss those if you would like.
And so now, commissioners, you can discuss the relevant testimony and written comments. I think before, yes.
I just wanted to give the commission some information and maybe clear up a couple misunderstandings in what I'm hearing from the testimony. So you already have an office-based surgery rule, which requires, among other things, the facility to be accredited. One of those, you approve those accreditation agencies or entities. One of those is the Planned Parenthood Federation, which I don't know the exact name, but I believe it's the Federation, but they are one of the accreditors that you have approved. If a facility is approved and accredited and follows the original office-based surgery rules, they do not need to follow this new Nitrous rule. This new Nitrous rule is for anyone who is not falling under the original rule. So if you are operating and using the original office-based surgery rule and have been accredited under that rule, you would not need to then follow this separate Nitrous rule. That's one thing. The other thing I'd like to say is that when in the Nitrous rule, when you're talking about a healthcare provider, a second healthcare provider needing to be there to administer, that does not need to be another physician, PA, ARNP, or other advanced provider, I guess. It could be any licensed healthcare provider that it's within their scope. So there are other professions that can, with certain supervision, provide that. So it wouldn't, I did hear that some of the commenters thought that it needed to be one of the PA and ARNP, another physician or a AA, but I don't believe that that was your intent or is in the rule at all. So it could be any level of provider that it's within their scope.
So would this be a medical assistant? Is that within their scope, or does it have to be an RN or?
I don't know. There are certain levels of medical assistant. There's medical assistant certified and phlebotomist and all sorts of medical assistants. So I can't speak to that today, but it's possible. I don't know if the medical assistant program has, I don't believe they've provided any interpretive statement on whether it's within the scope, but that would be a question for that program, but it is possible that it is within the scope. I don't know that for sure.
Thank you for those comments. Yes.
Madam Counsel, I want to thank you for that clarity. I think it's, what I heard from Planned Parenthood was disturbing. And so that clarity makes it really clear to me, and I appreciate it.
Anyone else, other commissioners have a comment? As the only anesthesiologist on this commission, I did want to point out a few things. I mean, we worked with, let me say, in the anesthesia community around the U.S., nitrous oxide is being very diminishingly used. There have been multiple concerns with use of nitrous oxide. A lot of our younger people concerned about the environmental hazards and global warming, although in reality, nitrous oxide is largely produced by agriculture, cattle, other animals, that sort of thing, and largely in industry. And the effects of nitrous oxide in, from pipes and other things that we use in hospitals and clinics and that sort of are a really small component from medical use. The biggest issue has come over, another issue, I see Dr. Bundy here, is the abuse potential. There's been, so that is always there. It's one of the other concerns with it. But I think overall, the major concern with use of nitrous oxide in the office setting is one of the occupational exposures, particularly to the staff working in the center. And keep in mind, there are a couple actions of nitrous oxide that are very concerning. One is it interferes with methionine synthetase. This involves in the conversion of vitamin B12 to folate. And it also affects the synthesis of the myelin in the brain, in the nerves, and the neurons and the nerves, and it affects DNA production and cellular reproduction. And it's been associated with DNA damage. And a known thing in the dental literature with those, and agree they are exposed to a higher concentration of nitrous oxide, but an increase in miscarriages and a decrease in fertility. And that's why scavenging, if they're scavenging in the dental offices, it's certainly avoided it. There have been some concerns in a variety of studies through the years about female nurse anesthetist, anesthesiologists, operating room nurses having a higher rate of miscarriage and fertility. I think that quality of that literature isn't as good, but that's out there and it is concerning. Now, the other thing is that it affects homocysteine, and this affects coagulation, endothelial adhesion, alters vascular responses, causes platelet aggregation as a procoagulant effect. And it is associated with prematurity and with preeclampsia in the patients. So when you have your staff who are working in these environments, and you have the use of effective scavenging, that can really reduce that risk. The other thing is it's become less popular in anesthesia for children because there have been studies, again, they're animal studies using high concentrations for long durations of time, but it actually destroys neurons. And I think a lot of the more cohort studies, the epidemiologic studies that show that kids, who had surgery when they were little, they still, while there's some of the stuff says, that maybe their cognition isn't as good or their school behavior isn't as good as other kids, a lot of those are subject to the fact that having a kid who has to have surgery at a young age means they're probably different. They have other issues there. So the safe occupational exposure is really key. And that's what we were trying to create with the scavenging system. Looking up the acceptable levels of from NIOSH, I saw that on labor floors, even with the intermittent nitrous oxide administration on demand, as opposed to in the dental offices where it's freely flowing, that there have been reports of higher than acceptable levels of nitrous oxide in person, in these areas for labor use. So it can happen. And I'm glad to hear you have the dosimeters, because that really makes a difference. I think if you're using that, I would recommend it for all your staff. It just is I think we were willing to look at this, and when the anesthesia community is saying this is a horrible drug, but we understand there is a purpose. It's just keep in mind that there's always a trade-off, and the trade-off is particularly the health of your staff and yourselves. So that's my only comment about it. I see it can, what's been doing. And again, I would recommend dosimeters. We didn't write that in, but it is something allows for you to detect if you are having an issue in your clinic. Anyway, that's just my point of view as an anesthesiologist. Okay. We'll see where we are next.
Real quick, Commissioner Poland has his hand raised.
Oh, okay.
You'd like to go ahead?
Yeah, I would like to echo the earlier comment about the concern with Planned Parenthood. When I first read through it, I too was very concerned about the impact that it would have on Planned Parenthood, and I am glad for the clarification that was made.
Dr. Curry.
So I appreciate the comments that came from Cedar River and Planned Parenthood and our testimony today. So I'm an OBGYN, obviously an advocate for women's health. A couple of things that came up were the dosimeters. So glad to hear that they're using that in Cedar River and have so far had a good experience in the sense that their levels have been undetectable or well below any OSHA regulations. That wasn't something that we had considered in our rules, and I would like to have the opportunity to potentially explore that more as potentially part of our rules. The other question that came up is we did say licensed provider or practitioner or something in the rule. And it dawned on me that in my mind, I was thinking it would be like a certified MA because that's usually who we work with in OBGYN offices. But if it's not 100% certain that a certified MA, for example, is within her scope or his scope to be that second person monitoring the patient, I would like the opportunity to know that for sure before we write it into the rule, because I think that is a really big barrier if it requires a higher level of licensing beyond that, as most women's healthcare offices don't have that. And then the concern about the scavenging unit that was brought up from both Cedar River and Planned Parenthood. Planned Parenthood, it sounds like Planned Parenthood is exempt, but there would be other offices where that might be a barrier. I personally don't know enough about the on-demand devices, particularly the newer models that are coming out more and more. This is being used in labor floors a lot in the last just few years. It's a relatively new introduction into women's health for use for nitrous, although it's been used in dental offices for a long time. So I think that maybe we need a little bit more time and opportunity to explore the devices and what data there does exist on the unintended exposure for the support staff in terms of the levels that they're being exposed to due to the on-demand devices, which we assumed were fine and didn't need scavenging, but may not be according to Dr. Domino's research. So I personally haven't had a chance to look at that data and look at the new devices. I did a little bit of research this week, but not enough to feel confident. So I don't know that I feel ready to adopt our rules as written without a little further investigation. Thanks.
Thank you. Yes, Dr. Chung.
Yeah, thank you. And again, I also wanted to thank Ms. Carter for the clarification. My concern is that maybe it's because I still need to learn how to read, but I don't see anywhere in the new section that describes the what you explained. And so I'm concerned about the potential future interpretation of these rules once that explanation may have disappeared from our memory. My second concern is that I am not supportive of mandating any technology without actually providing data that strong data that supports its use that should be mandated. And so again, I wonder if any other technology or any other alternative would be acceptable in lieu of requiring a scavenging system. So those are my two comments. Thank you.
Thank you. Any other comments or questions from commissioners? So it sounds like these are substantive changes that we need to discuss and think about further. And that, so I think, Ms. Boyd, can I just say that do we have to take a motion to adopt the proposed language when our discussion says that we need to think about it further?
You have three options. You can adopt the language as written. You can defer the hearing to a later date. But it sounds like you probably need to go with the third option, which is return to the 101, where you can do more language work. And then there'll be, we'll rescind this 102 and then, or file another one later.
Yeah,
We'll
so
return to the 101.
it sounds to me like we need more of a 101. And I'd appreciate if for those of you who online who've given your expert testimony, if we would have heard this earlier, we might have not brought it forward, but we didn't hear it. So please we now know what some of the issues there. So please do, when this comes up again, really, it would be great if we have some of your representatives there to help work with us so that we can get this right. And that, so we'll take a vote then that we want to defer this for further workup. You said move back to the 101.
Correct.
Yes. And then, so yes, I'm going to get a motion. I was just clarifying what it is. So does someone wish to make this motion?
So moved.
Yeah, Dr. Chung, and we have already Ms. Blake and a second and that. So all in favor, would you say aye? Yeah. Anyone opposed? Okay, so we will delay this and get back to work. And again, thank you so much to the public for your feedback. We really appreciate it.
Then we can just close the hearing.
Sorry. Thank you for your participation. Already said the hearing is now adjourned and the time is 10:12 a.m. Dr. Murphy, would you like to take a break?
I think everybody would appreciate a break, and we will reconvene at 10:30. Thank you.
Thank you.